Thank you so much. Thank you so much. So I think we'll continue with our academic session. So the next is a panel discussion, and it's a interesting topic on the timing of the RRT. So this would be moderated by Sreebhushan Raju sir, Bhushan Raju Devaraju sir. He's the senior professor and unit head at Nizam's Institute of Medical Sciences, Hyderabad. And I shall also introduce the panel who are going to guide you through this difficult thing. It will be Dr. V.S. Pavan Kumar. He's the senior consultant ICU and ECMO at KIMS Hospital, Secunderabad. We have Dr. Mahesh Kota. He is the consultant critical care nephrologist and transplant physician at Yashoda Hospitals, High Tech City. And and to join them is Dr. J. Vamshikrishna. He is also a senior consultant at ECMO at Department of Critical Care and ECMO at Kamalini Hospitals, King Koti. I hand over the session to you, sir.
I need to stand and they'll be sitting there. It's a punishment in the afternoon. So good afternoon, everyone. And probably I'm the most odd man out here in this gathering of all critical care specialists, being the nephrologist and along with Mahesh Kota. And today I know that now today is a Sunday, that too especially the afternoon. And the topic is very boring and dry. It's AKI, no urine output. And it's a post lunch, that too just few minutes, 30 minutes after taking the lunch. And it's a routine time for people 50 plus like me to take a nap in the afternoons. And that's why I don't mind if any one of you is actually trying to doze off and not so attentive about the topic. It's a topic, it definitely is interesting. And AKI, you know that you'll be called to see the patients or you'll be managing the patients critically sick and ill in the intensive care. And patient has an AKI. To be or not to be in a Shakespearean dilemma, and to give or not to give is similarly a Shakespearean dilemma in a critical care. When to give them a dialysis, when not to. And probably there can be a conflict between you versus your nephrologist. And there can be a plethora of investigations and clinical situations where you'll be dealing with, and a lot of dilemma. And of course, the patient and their attendants, and they also may not be willing. And the first question they will ask you is that, okay, doctor, you can start the dialysis now, but for how long? It will be there for throughout the life. And as if patients are truly going to come out in each and every critical crisis period. So I was told to moderate a session and ignite the three young, dynamic, two critical care specialists and one nephrologist. And I need to ignite them, and at the same time, I need to provoke them to extract as much knowledge as possible. It's not just theoretical knowledge about the 5 clinical trials which have been done in when to start dialysis, early or the late. How early is the early and how late is truly a late. And it's not only that, it's just I would like to get a real world experience and hands-on experience by them and the true experience of these specialists. Then when to dialyze. To start with, we have Dr. Pavan, Dr. Vamshikrishna, and Dr. Mahesh Kota. And you can see these particular 5 clinical trials, which I just kept it, but not as a reference, not to truly go through that. But Dr. Mahesh, so what do you think is actually exactly a situation of acute kidney injury and critical care setup, that when you are called to give an opinion to dialyze or not, what is the first thing you go and just see whether the patient has AKI or any other clinical situation?
A patient. First, I would like to know about the clinical history of the patient, sir. Before going and jump about deciding renal replacement therapy, I would go back to couple of days earlier and what happened to the patient, how he was treated before coming to the hospital, what fluids did he receive, what drugs did he receive, and what is the reason for AK. And every AK should have a particular diagnosis. And based upon the diagnosis, then I would go and put my treatment options for each and every patient. Because you have projected a slide which was showing big trials, I'm not a person where I should comment about these trials, which was very good trials, but I may not agree in the fact that we cannot decide about renal replacement therapy or renal support based upon the stage of AK, because the definitions are, yes, good definitions which include which stage the AK based upon the functional biomarkers and urine output. They are not stratified based upon the structural biomarkers, which will give some important indications about the clinical details of the patient also and prognostication purpose. In this area, as you said, coming to the definitions of AK, I may not agree about the staging of the AK and indication of renal replacement therapy. I would ask my co-panelists to tell their opinion.
Yes, yes, Dr. Pavan.
Um, so starting renal replacement therapy in a ICU, it comes with its own risks. That's why whether you continue conservative treatment, manage them medically versus going for renal replacement therapy is always a decision that we fight with, because it's very easy to say put a cath and dialyze them, but that's another physiological burden you're putting the patient on. So as sir has said, finding the reason for the AKI. If a patient has a prerenal AKI because of, let's say, diarrhea, just giving them fluids would probably be enough to resolve the AKI and get the urine flowing again. And at those points of time, even though the urine output may be zero for a few hours, and he fits into severe AKI, I might not want to dialyze him just because he's anuric if other parameters are okay. Whereas there are other cases where a patient has had, let's say, major trauma, has rhabdomyolysis, is acidotic. I know the clinical progress might not be as good because the muscle might block off his nephrons. There, I might go in for a renal replacement therapy earlier. So these are decisions not based on one clinical data point, let's say being anuric, etc., etc. You have to take the whole clinical scenario into your vision before you make
Yes,
that
yes. In
decision.
any clinical situation, in a critically ill patient and AK, with AK, the etiology of AK is very, very important and of paramount importance in initiating the therapies. You don't have to worry about the dialysis per se, but actually the etiology and finding out and treating the etiology is more important. Something like an antibiotic therapy for sepsis or something like that. Of course, the etiology also guide you when how early you can actually start the therapy. Something like rhabdomyolysis, where you can start a bit earlier when compared to the other clinical situations. It's actually very impressive that you started off saying that the preclinical importance of the clinical assessment of the patient. And what about the biomarkers? Actually, are you happy with the creatinine as a term? And what are the other things which you take into consideration? Like whether you are happy creatinine, because okay, we always say that the creatinine is okay, but in a critical situation where the things are going up and down, patient is hypercatabolic, so many drugs are there also there where which can interfere with the assessment and estimation of the creatinine. So are you okay with the creatinine? You would like to check with any other biomarker?
When it comes to biomarkers, sir, we cannot completely neglect creatine because it is widely available and most of us are aware about the creatinine, how it is being metabolized. But we cannot completely rely upon creatinine. As you said, definitely there should be a structural biomarker which can guide us in a particular way so that we can start implementing AK bundle for each and every patient where there is an elevation of a structural biomarker. Something like if we are very much aware that if we are going to put a central line or catheter, we know how to take a catheter bundle. In similar way, we should be aware of the AKI bundle also. So that, but creatinine is a substance which may get elevated after some amount of significant kidney function is lost. But if we can get a biomarker which is readily available in many centers, these structural biomarkers can allow us to do some procedures or to take care of the patient so that he will not going into a fulminant AK and he may land up in any dialysis requiring stage. Yes, sir, as you suggest, biomarker should be implemented, but still I think we are in a phase where which is an ideal biomarker for a AK and specific biomarker for AK.
Yeah, what about your experience in this?
Coming to me, sir, thank you for the opportunity, the critic team. It's a privilege to sit here and talk with senior nephrologist Dr. Bhushan, sir. Coming to biomarkers, sir, yes, they give us early identification of progression of the disease, which stage of damage is ongoing there. We have been studying or we have been seeing the some positivity of those biomarkers like NGAL and cystatin C, but routine usage, I still see the medium level centers or the district headquarters or the smaller centers, still we are not very sure of it, how early we can use them, because we are cost constrained country and cost constrained ICU. So yes, creatinine and urine output help us to predict, yes, we are bit delayed, but as the previous question we asked, we have to consider other things too, the clinical history, stage of AKI, progression of the AKI or disease progression which is affecting the kidney. These are all things does matter. Yes, if they are readily available, it is not a burdensome. Yes, we have to use them so that the prediction of AKI helps to predict the disease as well the progression. That definitely yes, but availability and cost constraints and are all those things are an issue.
Okay, my professor of medicine never wanted me to become a nephrologist. He always used to say that ARF, Lasix, CRF, Aludrox. Aludrox is aluminum hydroxide phosphate binder, which used to be there 25, 30 years back, which I never used in my life actually. That's a different story. But what about this furosemide test? Because whenever we call someone, even I think I remember as a DM student in All India Institute, I think I used to go and I used to write a furosemide and come back, just see whether it puts out the puts up the urine output. If not, then we'll think of that. So similarly, what about the furosemide, the stress test? How good do you think is that? Is it okay? Routinely, we can use it in all critical care
May,
situations.
may not be, sir.
May not.
May,
I also agree with him. May not
Is there
be.
anything significance given to that in
yeah.
the running around a very active and vibrant practice of critical care? We can depend upon a small injection of furosemide and just see the urine output improved, and you don't have to worry about.
Sir, uh,
So I think furosemide, just relying on furosemide for the AKI to improve, I don't think is a reliable thing, because what we get caught up in is you give furosemide, there is some urine which is coming, and then you get caught up in that, and it might actually delay your onset of renal replacement therapy, which might be what is actually needed for the patient just because you've got some urine.
Yes, the literature probably said that giving a furosemide in first 2 hours, if they produce 200 ml approximately of the urine, and that can predict, and those patients who improved probably did not require, who did not improve, almost 80% of them required renal replacement therapy. So, but in all the practical purposes, we don't really rely upon that. So don't think that the nephrologist will come and write a furosemide and run away, shrugging off the responsibility of giving a dialysis, but they will give it. Actually, according to Vamshi, then what is actually the best one, the indication for dialysis in a critical care situation, whichever way you are practicing? So in your clinical practice and your experience, what are the true indications where you like to start?
Uh, for initiation of dialysis in ICU, sir, I see the progression of disease and
Yes.
organ dysfunction. The as we discussed, the primary cause, disease progression, and involving other organs like uremic symptoms. It could be hemodynamic instability or severe metabolic acidosis. How rapidly the patient's other organs getting affected because of the ongoing renal damage. That is where I may take my call of dialysis early versus late. If the patient is not going into other organ dysfunctions, is able to wait, is not developing, is getting compensated, maybe we can wait there.
What about your experience? When do you start?
So there are strong indications: hyperkalemia, severe metabolic acidosis, fluid overload. But also we have to, as Vamshi said, looking at the clinical scenario of a patient. So if a patient is still in raging sepsis, severe septic shock on 2 vasopressors, urine output is dropping off, there is no point in waiting for him to get anuric and then get metabolic acidotic and then you start RRT. If a patient is in sepsis, is improving vasopressors wise and his urine output is slowly drifting down, maybe you can wait for some time to see when the hemodynamics improve, whether it improves. But if the clinical scenario shows that overall the patient is on a downward trend, then there's no point in waiting for a patient to become anuric and then only I will start renal replacement therapy is not a this thing.
Yes. What about Mahesh? What is your
yes, sir.
feeling?
I would also agree with my co-panelists. Do not wait till everything is lost. So if we can always anticipate at the bedside that this particular patient may land up in severe AK or severe organ injury related because of the organ crosstalk also. We would also take into consideration about, I would definitely take into consideration about preventing measures also, sir. So suppose in the morning 7 o'clock, if I go and see a patient whose urine output is just in the borderline, and if the patient has increased inotropic supports, and if the patient has normal acid base status, I would not jump and treat with him with him with too much IV fluids, or I would not rely upon furosemide test. I would take an opportunity to restrict fluid intake and see whether I should not push him in dialysis stage, like I should not remove the water that what I have given in the morning itself. So just be careful at that point of time. Do not take any measures so that you are going to dialyze the patient for the treatment what you have given for the patient, and take a call if there is any severe major indications like severe hyperkalemia, acidosis, complete oliguria. These are the major indications where definitely I would go and treat him. But if these are not there, I would just be cautious.
Yes, all the three experts here, they say that it is a clinical assessment of the patient and so many other variabilities and parameters which are there with the patient, something like his blood pressure and other parameters, but take into consideration the clinical situation rather than truly going by the numbers of the creatinine or just a urine output. For the sake of randomized clinical trials, we have an early, which is between 8 to 12 hours, and the late is truly the indication, something like an uncontrolled hyperkalemia, uncontrolled metabolic acidosis, or pericardial complications like a pericarditis or a neuremic encephalopathy. These are the situations which we routinely consider in giving dialysis. But the experts here, they say that it is a clinical situation which is of very important in taking a decision of that. Once you take a decision that, okay, how long you will wait actually, that whether you wait for some more time or with is a threshold at which you can stop thinking
Yes,
about
sir.
it.
Based upon, I think you're going to tell about demand versus capacity in your next slides, because but if I feel that if the demand on the kidneys is very high and if the kidney has a less capacity, then I would like to treat that patient. For example, now in our unit, we are doing CRRT for a aplastic anemia bone marrow transplant recipient. His serum creatinine has increased from 1.6 to 2.6. He doesn't have any metabolic acidosis or hyperkalemia. But if I look into history prior today is day plus 22 of bone marrow transplant. From day 0 -5 to this time, when I examine him, he is overall 16 liters cumulative positive. So by giving whatever the amount of fluid, he is hardly pouring 50 ml per urine per hour, and his body weight is 100 kgs. So I think the amount of the demand on his kidneys is way significant higher when compared to the capacity on his kidneys. So to allow nutrition, because he also had a CMV reactivation, to allow nutrition, to allow him the amount of antibiotics that he require, I have started him on CRRT. So in this way, if we can balance between the demand and capacity, and if we can anticipate that the capacity is very low, we may need to start in early. Even this type of early renal replacement therapy, even we cannot even call it as renal replacement therapy. I would like to call it as renal support also.
Support therapy.
Even I'm enhancing his kidney recovery. I'm enhancing the load on other organs, and the effect of crosstalk between each and every organs will also be decreased significantly. And I think he may do better in a couple
What
of
about
days.
Pavan and Vamshi? You have any other to refute with him that a similar opinion or a different? So is here the nephrologist or the critical care specialist will not sit like an obstetrician with a watchful expectancy and masterly inactivity. He'll be doing so many other activities, also giving antibiotics and fluids and all other thing. But it's not the creatinine alone or the urine output alone, and so many other parameters will be taken into consideration in initiating the dialysis therapy. Okay, once you are okay and comfortable saying that this is a threshold beyond which I should not really wait and see, and then when will you, which modality you would like to? I know that you are in a corporate culture, but look at me also, I'm in a government institution. Think of that and you talk about the
Yes,
modalities.
yes, sir. As you said before starting the discussion, if someone comes and a patient or any other of your non-nephrology co-consultant comes for any opinion, if you tell that this patient require dialysis, the next question that they ask you is how long you are going to do, and whether my patient will become dialysis dependent, or if the patient is asking, he may ask that I may get dialysis dependent. I think we should concentrate upon an area like the dialysis modality which is renal friendly also. Every dialysis modality, yes, like just couple of sessions before there was a discussion about intradialytic issues. We should not allow the dialysis as a treatment which can harm any other organ in the body. If I am very comfortable with this SLED kind of modality, I would also use a SLED in such a way that if my target is only ultrafiltration, sir. Say for example, a patient comes to our unit with significant cardiogenic shock, and if that patient might be having a normal renal function and mild metabolic acidosis or normal acid base status, but he is flooded with pulmonary edema, and we may not be able to use diuretics for that patient because of the shock. Then in that case, I would like to do a SLED if I am in a resource limited setting with a minimal amount of ultrafiltration, which so that I can run the dialysis over 12 hours or even by changing the filter for continuous for 24 hours also. In my mind, I would think I would like to take an opportunity that I should not harm the kidneys, and I would be able to do some justice to the patient that he should not become dialysis dependent. And this kind of wrong concept should not go into public that once we do dialysis, the patient will become dialysis dependent. So even this kind of techniques or this kind of practice can be done in a small center also, where but if you should be able to understand the machine properly and machine knowledge of the machine and how we are treating the patient. And also
Yeah. What about your opinion about the modality? You have CRRT, we have intermittent HD, we have a SLED, we have acute PD also in our situations of government institutions. What about your opinions?
For I am this critical care where I am practicing, sir. Definitely, sorry to say, I don't have much experience with PD. Only I heard or learned few points about PD can be applied in acute scenarios too. It is as safe as, and it can be used for a long-term scenarios as well as acute scenarios. But my knowledge is very limited in that aspect. Only thing is you need to take care of your peritoneal infections and your sugar controls, and it has to be properly trained. But coming to my more expertise come with a SLED and CRRT, sir. In acute emergency scenario or we prefer CRRT. If it is not available, we'll try to bridge the gap with the SLED, sir.
You
I think
also
in our scenario,
vote in
SLED
favor
is
of
probably the
CRRT?
best balance we have between having the hemodynamic stability and the slow solute removal of CRRT and the hemodynamic effects of the hemodialysis. So SLED is what we usually prefer unless the patient is really unstable and or we need solute removal very slowly, where like ALF and all those cases. But otherwise, we mostly use SLED. But again, the modality, more than the modality, is it's how you set the machine for the blood flows and the filtrate removal and all of that. You can have SLED with whatever setting, but for that stability and fluid removal, how you set the machine is, I think, more important.
when it comes to sir, when it comes to acute peritoneal dialysis, if there is an option, I would always choose an peritoneal dialysis, because peritoneum is like a medium flux filter. Our peritoneum membrane will be a medium flux filter, and for a particular patient, if there is an option, I would always opt to go for PD. I know because it
Do
is
you
very
select any
hemodynamic.
specialized, any special situation
Yes, sir.
like for acute PD?
In acute heart failure, it is one of the
Yes.
best modality that we can use peritoneal dialysis. Patient will do dramatically better with acute peritoneal dialysis in heart failure. And even now we are doing a small study that I am going to observe about ascitic fluid ultrafiltration that I am doing in a patient with end stage liver disease who is going up for a liver transplant, where I cannot do a routine hemodialysis or SLED because it will significantly impair the functional residual renal function. By doing this ascitic fluid ultrafiltration, we can definitely decrease the diuretic load, and we can increase the perfusion to the vital organs, including the kidney also. To cut it at short, PD is available. I would opt it for it.
Is acute PD is a situation, is a good modality only in a government setup and resource limited areas like our institute and even Usmania Gandhi. We do a lot, even as a student here and there. Most of the government institutions will be using acute PD, but it's specialized severe sepsis and multi-organ failure. PD may not be of much value, and probably it will add further burden of the catheter insertion, the technique, complications related to, and the solute clearance may not be as expected as you expect in a CRRT and other modalities. But still, as Dr. Mahesh said, it is a congestive heart failure patient in a severe heart failure, as well as patient with a neurological impairment. The recently a neurological episode, something like in a stroke or in a bleed. So these are the patients they would do well when you really do acute PD, because acute PD is very smooth and sensitive procedure. and that can tackle the uremic environment in the body in a much better way compared to a very dynamic and very aggressive procedures called hemodialysis. And other modalities like either be it CRRT or a SLED, we have actually equal, and depending on the cost effectiveness. What do you think the cost effectiveness of these modalities, the SLED versus CRRT? Which one you prefer? It is which is more money earning or revenue generating, or it is basically the outcome based or the patient dependent?
I think I mean, SLED is much more economic
Yes.
as for us.
But as one of the important things which Mahesh actually stressed upon is the insult to the other organs during the hemodialysis, especially when you are very aggressive with ultrafiltration and all, there can be other organ involvement in the form of a relative ischemia to the brain and also as well as to the kidney, the liver, and even a further injury to the kidney in the form of repeated hypotension. Somebody was talking about hypotensions during
Yes,
dialysis.
sir.
So
When it comes to cost per se, yes, I would also go with the SLED or hemodiafiltration modality, because in our unit, suppose if I am doing I can see the bills from the billing department. The SLED, the bill for SLED for 8 hours, it will be 11,000 rupees, and if I am doing a HDF, it will be 15,000. But once we start CRRT, without having a huge amount of getting deposited, they will not give clearance for CRRT also. So if we are able to do a better job with SLED or hemodiafiltration, if it is available in our unit, we can always go with these modalities and see, sir. But do not make your dialysis prescription in such a way that it is going to harm the other organs as well.
okay, like the clinical course of the patient also equally important. How do you monitor them beyond the discharge? Like if at all the patient comes out, and what are the things which you would advise them, and who are these people who should really come back again to you and just
Yes,
see?
every being a nephrologist, we know that every AK patient should be followed, and definitely if a patient requires dialysis, he should be followed aggressively, because most of the patients directly do not get discharged from hospital. Like if the patient is on ventilator support or CRRT, we will not discharge them directly. There will be transition from one modality of dialysis to other modality of dialysis also. So at the time of discharge, as like we would always check the urinary creatinine and urinary urea clearance when I am weaning off from the CRRT. We are not comfortable at this point of time to depend upon furosemide stress test to see whether the kidney is going to recover. We will always see that apart from looking into the blood urea and serum creatinine, we will also see timed urinary urea and creatinine clearance. If they are getting improved, then we will may wean him off from CRRT. For the first week, we will always of the first week of the discharge, we will check for proteinuria and serum creatine, and what is the weight gain of the patient, whether the patient is going into volume alert state or not. And after that, if he is completely fine for the first 3 months, we would like to ask them to come for monthly once, and we ask them to see whether there is any drop in the urine output or increase in creatinine or increase in proteinuria. If they are not there, when we will ask them to look monitor every 6 months, and we will advise them not to take any nephrotoxic medications, because if there is a dialysis requiring AK in once in a lifetime, there will be significant loss of residual renal function, and a minor insult on that particular kidney will definitely impair his kidney, and he will knock off his kidneys, and he may get into dialysis dependent stage, and he will take in his lifetime that the myth that once we dialyze, the patient will get dialysis dependent. So we will need to follow him very aggressively, definitely, sir.
Yeah, yeah. Pavan, you can take up this actually. You any difference between the etiology wise, the renal something like a post cardiac surgery and something like a sepsis? Do you find any difference in the initiation and maintenance of dialysis and outcome in your experience?
Generally, in critical care, when we start on an emergency basis or a patient when he's going down or to avoid crosstalk, initially maybe the urine output drops down, his creatinine jumps up, but maybe during the next sessions of dialysis, which we are doing usually later, we expect there should be some amount of urine which is coming, at least some amount. He shouldn't become anuric, he shouldn't become go into ATN kind of scenario. There we'll be hopeful. We can tell them that there is a chance of kidney recovery as early as maybe 2 weeks time or 3 weeks time. But maybe during the he may recover completely, but if kidney doesn't recover once the underlying causes, then it is a warning time, or kind of maybe we need to start prognostication to the family that he may become dialysis dependent.
Okay. And one of you stated that you have to understand the machine properly. Yes, the machine is very important. But what about the machine learning, which has become a very important topic nowadays, artificial intelligence, and what are these models which can really predict when to dialyze and when not to dialyze? Do you think you foresee any such a situation in the future that the machine learning models will come into picture and where they will guide the specialist in giving a dialysis or not to give a dialysis or anything like that?
As of now, I think we should concentrate we should not depend upon artificial intelligence
He
at
says
this.
that better use the brain
But,
rather than the machine, he says.
but I would not, I would agree upon you, sir. I don't want to depend upon artificial intelligence. We can always spend some time and we can do justice for the patient.
Okay, there are at least 3 or 4 predictive machine learning models which have actually predicted when to give, especially the outcome-based modalities also. And any other thing, actually, we have actually time up and there's a bell. And thank you. And you know that the AKI in a clinical situation is a difficult task. And for the past 3 to 4 decades, there's not much of improvement in the outcome, especially when it is measured in the form of mortality, as far as the AKI is concerned in a critical care situation. So there are so many things. Antibiotics have come up, the dialysis modalities have come up, but ultimately the outcome based on mortality is the same for the past 3 to 4 decades. So we need to do a lot of things and we have to learn a lot and we have to put in so many efforts to improve the outcome in patients with a critical care situation in ICUs with the AKI. And thank you. I thank the panelists for giving their real world experience rather than going theoretically the 5 studies and telling again and again repeatedly of the same. I hope you understood a little bit about when not to dialyze the patient in a critical care situation. Thank you all. Please.
Thank you, sir. Before you leave, sir, the ICSM Hyderabad would like to felicitate.
Can I have a quick
Oh, sorry.
question, sir?
Yes, Oh, sorry.
Actually, mixture of critical care and nephrology, so it is always privilege to ask some questions. What we, as a critical care specialist, will have always a doubt. See, like as you have shown the slides, the studies, the last 2 studies, Start AKI, which was around 3,000 members were there. Even the latest one, what is Start AKI 2. Even this ideal ICU, all 3 studies are done in like septic patients, ICU patients having multiple organ dysfunction. They have seen like KIDIGO 2, KIDIGO 3, I think urea is only taken in AKI 2 and other things they have not taken even urea and create also the values. Apart from the urgent dialysis where there is, let's say, severe hyperkalemia or hypoxia and all those things, they waited. And most of the study they have seen one thing: delayed is better than early. Early means whatever we have discussed now. Second thing is, if we delay dialysis, almost 30% of people they didn't require dialysis, and renal outcome is also similar in both cases. AKI 2 per se, the AKI 2, if I am not wrong, the Apache score of the people who have been in control and study, there was 28 plus 2 or minus 2. 28 means they are really sick. They are multiple organ dysfunction and all. There also they didn't find much of benefit if you do early dialysis. So how true we are, like Dr. Mahesh told, like they are doing dialysis, even if the patient is having 50 ml urine, there is no acidosis. How can we justify that? That's
So
my
as I
question.
said, sir, there is an important thing that I mentioned about demand versus capacity. In that particular patient, as I can anticipate, the amount of urine that what he is getting is not enough to make him dry, definitely. And I cannot restrict his fluid intake, and we cannot restrict his antibiotic, or we cannot restrict his nutrition. So in that particular point of time, we may definitely take into consideration to support his kidneys, number one. And coming to the trials that what we have discussing till now, most of the outcomes in these trials, they would always see the mortality benefit as a first point of time, and at the same time they may in future in the some of the trials, ongoing trials, they are seeing about major adverse cardiac events. If we am doing a particular study about renal replacement therapy in a critical ill patients, in this era or at this point of time, we would also see about major adverse renal events. So as everyone or every patient, every family member of the patient or any other other specialty doctor, they will always ask about only one question, as Sreebhushan Raju sir told: how long this will be continued and how long we are going to whether my patient will get dialysis dependent. taking it as an example like intubation and for a patient who is suffering from respiratory distress. When I was a resident in 2011, when I'm trying to put some patient on a ventilator, some physicians as well as anesthetists, myself and patient attenders, we used to think that whether this patient will get any benefit from intubation and ventilator support if the patient is critically ill. I am not talking about patient who is getting intubated in an anesthesia room. But over a period of time, we came across proper intubation techniques and ventilation techniques and how we are avoiding other organ injury because of the ventilator. We will also come up in a situation where we will avoid complications related to dialysis. If we see about in these particular studies, they say about catheter related bloodstream infections or any when we are trying to put a catheter, is there any mechanical complications during catheter placement? They are all taken into primary consideration, but they did not see about how the dialysis prescription is affecting the other organs or even the kidney itself. If we concentrate upon the dialysis as a pure treatment modality which is not damaging other organs, we can always offer it in a early way so that we can take all other precautions to prevent kidney injury, cardiac injury, and even other organ injury also. So I would be justified in a such a in a particular patient if his demand is very high and if his capacity is low, definitely I would offer him renal replacement therapy.
I think that is sufficient enough. And any other question also we would like to take the panelist, because I did not come prepared actually, because I'm a moderator and I'm a seasoned DM and DNB examiner. I know only the questions. I don't know the answers actually. Most of the time, and he gave such an elaborate answer in the examination also. He did the same time. I was number of times I was the examiner for him actually. Now I have to recapitulate that how much he answered there in the examination. He forgot. Yeah, we thank the organizers for giving this opportunity.
Thank you,
Thank
sir.
you.
I'd request the panelists to still please wait on stage.
Yeah.
I invite Dr. Madhusudan Jaju, sir. Sir, to felicitate the panelists on behalf of the ICCM Hyderabad. So first I would invite Mr. Jaju, sir, to please felicitate Sreebhushan, sir. Dr. Mahesh Kota, Dr. Vamshikrishna, thank you so much. This will be the end of the, yeah, he had it. We had- So thank you so much. So this is the end of the session. Now we hand over the session to Dr. Durgesh.